Good afternoon and welcome. Five Wishes is pleased to present today's Practice Community webinar, Advanced Care Planning, Legal and Policy Discussion, with a focus on patients and providers. My name is Dave Simonson, and it's my pleasure to host and introduce today's webinar. This webinar is being recorded, so participant audio is muted. If you need technical help with the webinar, please click the Q&A button on the lower bar of your Zoom screen. Describe your issue, and I will do my best to help you. This presentation will last up to 60 minutes, and you're encouraged to ask questions throughout. To ask a question, click on the Q&A button on the lower bar of the Zoom screen. Type your question for the presenters. It is now my pleasure to introduce Kathleen Taylor, Healthcare Programs Director for Five Wishes. Kathleen.
Thanks, Dave. And thank you everyone for joining us today for the webinar, Advanced Care Planning, Legal and Policy Discussion, focus on patients and providers. This is our 13th Five Wishes Practice Community webinar, and we're delighted that these continue to be so well attended and appreciated. I think we have around 800-ish registrants for the webinar today. So we're delighted that you continue to find these relevant and of use. For anyone who's new, the Five Wishes Practice Community is for any and all healthcare professionals who are using Five Wishes tools and resources. So whether you're using the Five Wishes documents, our training solutions, conversation guides, patient education tools, outreach material, anything, custom-built solutions, anything that Five Wishes offers in our program for healthcare, if you're using any of those things, the practice community is for you. And our primary goal with the practice community is to help ensure the high quality of your advanced care planning work and to empower you to have truly meaningful and effective conversations with the people that you serve. We want to make sure that that's happening when you're using Five Wishes tools and when you're not. But this is an added bonus for using the Five Wishes program. We do this by sharing and highlighting best practices on these webinars and through other mechanisms, and sharing innovations and thought leadership. And that's what we're going to be doing today. So we hope you find today's webinar particularly useful. We have the honor of hosting some thought leaders and experts in the field of advanced care planning policy and legal aspects today to talk about lots of things that we'll get into shortly. And we're so grateful to have each of them joining us today. So if you all can turn on your cameras, I will introduce our panelists today. In no particular order, except maybe alphabetical, we have Maraset Hassan. She serves as the Senior Policy Advisor for CTAC, the Coalition to Transform Advanced Care. And CTAC is dedicated to improving the lives of people impacted by serious illness, advising decision makers, and leading a coalition of member organizations to advocate for the policies that ensure greater access, equity, and enhanced quality of life. Maraset began her career as an oncology nurse in 1981. She's been CEO and president of the Carolina Center for Hospice and End-of-Life Care since 2018, following a career in healthcare and hospice. Thank you, Maraset. In her role with the Carolina Center, she works with community stakeholders engaged in the delivery of end-of-life care in diverse settings, in addition to working with hospice and palliative care providers. Welcome, Maraset. We also have Sarah Hooper. She's the executive director of the University of California, San Francisco UC Law Consortium on Law, Science, and Health Policy, and a lecturer in law at UC Law. She also serves as the co-director of the Master of Science in Health Policy and Law degree, and the policy director of the Medical Legal Partnership for Seniors Clinic, which we'll hear more about. Sarah has dedicated her career to developing innovative medical legal collaborations that can advance equity in healthcare. She has a special interest in complex care, and in particular, the role of law and lawyers in improving systems of care for underserved older individuals with complex medical and social needs. Welcome, Sarah. And we have Paul Malley. Paul is the president of Aging with Dignity, a role he has held for 21 years now. Paul is a national expert and advocate for quality and dignified care at the end of life. He served on the Florida delegation for the White House Conference on Aging and has guided the efforts of several aging advocacy groups to improve policy on advanced care planning and patient rights. He has testified before state and federal legislative bodies in favor of patient-friendly policies and is a frequent national presenter at palliative care and aging advocacy conferences. And he's presented in Canada and Australia as well at international conferences on improving end-of-life care. So welcome to all of our panelists. Thank you for being with us. And to remind all of you, this is going to be a discussion. We're going to have a facilitated discussion together and talk about advanced care planning, legal and policy issues with the folks that we've got here today. So what I want to say, just to start us off, to revisit the framework of this topic, advanced care planning, effective advanced care planning is, as best as I can understand it, a systemic endeavor. It involves educating providers, patients and families and communities, coordinating, eliciting and listening skills, documenting, witnessing, information sharing, storing and retrieving and updating, and good decision making. And all of this requires a system to do it well. To be effective, advanced care plans need to be medically sound with decisions that are clear and able to be honored by medical professionals who may be present when the time comes. And they need to be legally sound with wishes elicited and documented in ways that ensure their validity and integrity. And most of all, advanced care plans need to be understood and understandable based on clearly and thoughtfully informed choices reflecting the unique values and experiences of the human beings that they concern. So it's kind of a lot of legs to a stool here, but it's a systemic issue. And thinking about the collaboration between medical and legal communities and the people community, I wanted to first start with you, Paul, and just see if you could give us a general background of how the Five Wishes program did that, because it's a pretty good example of partnering medical, legal, and human beings in the community to build something new.
Sure. Thanks, Kathleen. And it's good to be part of this discussion with you, Kathleen, and Sarah and Marisette as well. So I think, first of all, the very title of this webinar is interesting. Advanced Care Planning, Legal and Policy Discussion with a focus on patients and providers. So you have 4 different lanes there that sometimes are seen as being in conflict. And I hope what you'll see today through our discussion is that there are ways that we can harmonize this. What we've noticed at Aging with Dignity, the nonprofit organization that created Five Wishes, when we looked at the process of advanced care planning in the late 1990s, we saw that the documents, the process that was available to people to complete an advance directive, it was very legalistic, transactional. Some of the first generations of living wills or advance directives were written in language that was very difficult to understand. And there's a reason for that. When you go back and look at kind of the genesis of this idea, it really began in earnest in the late 70s or 80s, when there was a need for patients and families to be able to communicate what their thoughts were regarding life support treatment, especially trauma emergency treatment. And to help with that, attorneys and then eventually legislators, mostly in states, came together to craft laws and policies. Most laws governing advance directives are really written into state statutes and decided by state legislative bodies. So any of you who have been in any legislative committees know what an interesting situation that can be. And on the policy level, we have state departments of health as well as CMS giving guidelines, giving guardrails for advanced care planning. And our first focus, our primary aim, was to look at advanced care planning from the lens of the individual, from the patient and his or her caregivers, family and professional caregivers. And there we also saw that there were some pretty clear headlines of what people cared about the most. When you ask people what would be important to you if you're approaching the end of life, people say, I want to be at home, I want my family to be with me, I want to be comfortable, I don't want to be in pain, I want my human dignity to be respected and protected and maintained. And they would also have some thoughts about treatment decisions, life support treatment and otherwise. So our idea that eventually led to 5 Wishes was that we actually could harmonize these things and put them together, that we could create a form of advanced care planning and a program for advanced care planning that had as its primary focus what was most important to patients and families. And here's where I'll underline that and also follows state legal requirements. I mentioned that it's state statutes that govern advanced directives and their policy and their law. We were grateful to work with the American Bar Association, Charlie Sabatino at the ABA Commission on Law and Aging, and looked at the statutes of all 50 states. And here's a pivot point. We could have decided and made the decision and crafted 5 Wishes around the idea that clinicians would want to honor a patient's wishes no matter how they're expressed. And I think that's true. And I think that would happen. What we chose was what the ABA called the gold standard approach, was to put that discussion, the 5 Wishes document, in terms that were understandable to the patient and that satisfied the legal requirements written into state statute. So that was intentional, that we would create a document that did both and. And since then, since it was introduced nationally, it met the legal requirements in 32 states. Today, it meets the standard advanced directive, standard 5 Wishes document, meets the advanced care planning requirements in 46 states. So there are just 4 outliers, and we have solutions for those states as well. So on the grand scale, we've seen the pendulum swinging, we think, in a positive direction to give people more flexibility to make decisions on their own terms. And then what we've created, and Kathleen, you've been so helpful with in the 5 Wishes practice community, is making sure that the legal and the policy requirements are met so that hospital legal counsel can also have peace of mind to know that advanced care planning that's happening within their institution is following the legal requirements. And from their perspective, I would underline that means that all of the protections that are written into state law and state statute, the immunity provided to healthcare providers who are acting in good faith and following a patient's wishes, those are all guaranteed only if that document meets those requirements. That's why we think 5 Wishes has been so successful and well received on the patient side and the provider side. And then this practice community now is providing more resources for the clinical side so that it really does harmonize all these parts of the advanced care planning process to show that it can work for all the interests of each of those groups.
Thank you. I like how you talked about the gold standard really being that things are understandable. I mean, if it's not understood by the people who need to understand it at the time when the need emerges, then I think all of us who've done this work have seen people who've done the work of advanced care planning, and then, you know, and it's rare that this happens, but these are the stories that stick with me, are the times when it didn't work because somebody didn't know or understand what the wishes were that were being conveyed, or the wishes were conveyed in a way that was medically conflicting. You can't have this and this. So the informed choice wasn't medically informed in a way that actually was actionable when somebody needed that to be. So I like thinking of the gold standard as being something that meets all of those requirements. And Sarah, I want to ask you as well, with the medical legal partnership just seems like exactly what Paul is talking about in everyday working action. So can you tell us a little bit about how that started and what that is today?
Yeah, thank you so much for having me. It's really lovely to be in conversation with you all. And I couldn't agree more with sort of the general principles that you've outlined around advanced care planning. I'll say a little bit about the medical legal partnership model in a minute and what that actually looks like, because it's actually been around for a very long time and exists in about 400 health systems around the country, and it's an evidence-based model. But its applicability, I think it's particularly important in advanced care planning. And I think about the role of lawyers, I think a little bit more broadly in this space. And I think about it in two ways. So one, as a partner for ensuring that these documents are accessible and that they reflect the wishes of the patient, and that they are legally valid, but also that lawyers, and I think in particular about community lawyers who do broader disability and estate planning, have access and skills in tools to address the socioeconomic context in which people are stating goals of care. So if your goal of care is to age with dignity in your home or to die in your home, but the conditions in your home are not conducive to that, or you're about to be evicted, and you don't have anyone to help manage your finances, your medical goals of care are not realistic. Right. And so I think more broadly about the role of lawyers in this space. And I think about our relative sort of skills as being complementary. And so I'll say that that's sort of like the big picture of what has come up for us in the medical legal partnership. So a medical legal partnership is a healthcare delivery model, as I said, in about 400 healthcare systems around the US, in which lawyers are integrated into delivery of healthcare. And we do sort of three things. One is we provide training, and we also receive training in partnership with healthcare teams around joint sort of medical legal needs and advocacy of patients and caregivers. Training is huge. It is probably the most, I think there's a direct advocacy piece, but I actually think the training piece is really eye-opening for everybody. And it has been for me and for my colleagues as well. Second, the healthcare team can actually make direct referrals to the legal team to actually provide advanced care planning or other services like housing advocacy, appointment of durable powers of attorney for finances, which are critical, other estate planning. Some do help with immigration or other kind of broader family issues that come up. And that service is free to patients and caregivers, and it's targeted to people who are often the least likely to have access to those services in the community. So we're really focused on complex care. That's kind of the population we're looking at. And third, we do systems change together. And it's sort of it becomes a natural consequence of learning together, advocating together, and then seeing, oh, these challenges are coming up repeatedly. What can we do differently together? So that's the medical legal partnership model. And so in this context, we're working really closely with healthcare teams to understand what the clinical realities are, and then help explain sort of the nuts and bolts of the different forms when each is helpful according to state law, and then help kind of myth bust around, perceptions of, well, this form, I don't think this form is actually valid, when actually it is, or could we create a new form, or how do these forms work together? So we definitely do that kind of thing as well. And I guess I'll just add, and then I'll just stop and see, Kathleen, if you have any follow-up questions. Lawyers in the community are a part of the advanced care planning workforce. A big part. And we know from some studies in California that patients self-report that they are actually more likely to engage in ACP with lawyers in the community than they are with clinicians. And whatever you think of that, lawyers in the community are part of the ACP workforce. And so I think our goal should be, how do we better engage and improve quality of advanced care planning among the lawyers who are already engaged in it? And, you know, in the work that we've done with the ABA and the American Academy of Hospice and Palliative Medicine, you know, we found that there's just a real disconnect between kind of the thinking around advanced care planning as it's evolved in the last 10 years in healthcare systems and community lawyers who have not been part of those conversations. So are like dutifully churning out documents with really no awareness of these conversations that are happening, and kind of an assumption that these forms are more helpful than they sometimes often are. So that's a little bit about our model, and I'm just going to stop there and happy to say more.
That's, I was trying to write down so many things that you said, because I'm glad this is recorded, because I'm going to go back and revisit that. That was a really great outline of the benefits and the purposes of the medical legal partnership. And I have to say, we have, you know, probably mostly healthcare folks on the webinar today. That's, you know, the practice community is made up mostly of healthcare system, people who work in healthcare systems, some who may be legal counsel, but most of which are probably clinicians on the call today. And as a clinician myself, I will say that I have that oversight, that blind spot that you mentioned is something that I have experienced myself, because we often feel like, you know, the most important part of advanced care planning is making sure that these wishes can be honored at the time when someone is dying, and that's what they said they wanted. And what you just said about the really it's socioeconomic factors and other pieces of that, unless you've had a case manager, social worker who's really dug into that stuff, even if you have, they're still going to have to get some legal advice on some of these things. And I'm thinking about all the patients I've worked with who needed Medicaid counseling, and that ends up being a referral to somebody who understands the legal aspects of that and can help them qualify for the kind of assistance they need to get what they want. That was tremendously helpful, and I hope that's given everyone as much of a light bulb as it did for me. I do want to ask you kind of as a follow-up, what do you think are the primary, with your experience and with the 400 programs that are out there, are there kind of sets of primary issues? I know there was a medical legal panel, an interprofessional panel that was convened that made recommendations. Are there anywhere kind of here are the things that you should be considering and how you should be partnering?
That's a great question. So we convened an expert panel, a medical legal panel around advanced care planning in 2018. We did this in partnership with the ABA and American Academy of Hospice and Palliative Medicine. And essentially, we're just trying to get a sense of their state of the state of these disconnects between these worlds. And so we did individual interviews, and then we met in a day-long convening and sort of iteratively asked people their opinions, summarized, shared back, and then developed a set of medical legal ACP principles and actually a practice guide for lawyers that the ABA, I'm happy to say the ABA House of Delegates adopted by an overwhelming vote in 2019. And the hospice and palliative care folks disseminated it as well. And I think, I don't think the principles will be very shocking to this group. I think they're probably things that are very common, but I think that this was one of the first attempts to really bring estate planning lawyers, elder lawyers, law faculty like me into this conversation of what advanced care planning should ideally look like. And so we published this work. We published the principles and we published the practice guide. And I think sort of just a few quick takeaways, we sort of concluded that the most important legal component at this stage of advanced care planning is careful selection and appointment of agents, but that, our goals of care can and should be addressed in clinical contexts. And again, I think that lawyers can have a role here to support goals of care, but our skill set is really in addressing social determinants of health. That's actually what we know more about. And so I think that we can help support patients, clients in understanding how they're going to pay for, how they're going to marshal the resources they need for long-term care and for end of life. And that is, what are your goals financially? What can you actually do? But the healthcare agent piece is a really critical legal piece because it dovetails with the rest of legal planning, right? So in some states, healthcare agents have absolutely no authority over health insurance. And so you have to give it to them. You have to give that to them in documents, or you have to give it to your financial agent. So it makes sense that advanced directives are part of standard estate planning packages, because if you think about addressing a decision-making plan for a whole person, you're figuring out the decision-making architecture across all elements of your life, right? And so how your healthcare agent is interacting with your other decision makers is something that should be very thoughtfully done. And we also, because people are getting care across multiple systems of care, a note in a chart that someone is an agent is not as helpful as a durable power of attorney or healthcare. So we kind of separated out goals of care and really thoughtful conversations about goals and preferences from the legal decision-making architecture that lawyers are better at, frankly, and we do more consistently, I think, and prioritize more than I think is happening in healthcare systems. But certainly there's a shared value that advanced care planning should be an ongoing process. It should be focused on values, goals, and priorities, and not specific treatments for sort of hypothetical futures we can't really predict. The forms are really helpful as, conversation starters and not an end in themselves. We want more widespread document sharing. And then, of course, we do think there should be greater medical legal coordination, at least in training, if not in practice.
That's extremely helpful. And I'm thinking as you're talking about this, it's causing me to think about if you, and I've drawn this before somewhere, but if you were to kind of draw out the process, advanced care planning is it's an ongoing process because these decisions need to be revisited with any significant change in a person's condition or their life or their support system or their resources, all those things that affect the wishes that are documented. It's also a different conversation when a person is healthy and it's purely hypothetical than it is when it starts butting up against what we would call a serious illness conversation, which still involves some components of advanced care planning, but also begins to involve some prognostication and talking about likely complications, likely symptoms, how those can be managed, really getting into those kind of medical fears that are specific to this person's condition. So I'm thinking about how crucial that partnership is, because as you said, there's a place where the lawyers are just better at doing some of this procedural stuff. And there's a place where the medical professionals, with training and skill development can be very good at that other piece, which is really helping to inform the decisions so that people understand the thing you're saying you want is really not medically possible. Just like you were saying, sometimes the thing you say you want is not possible with your resources or how you're legally set up, but sometimes it's not medically possible. So I really like the idea of partnering to make sure that all those bases are covered. And as Paul was saying at the beginning, and having it end up in language that's not legalese. I think that speaking as a healthcare provider, I'm only speaking for myself, but I'm terrified of legalese. I'm terrified of things I can't understand and trying to present them and to a patient where they just look at it and go, oh my God, I don't know what this means. And trying to translate it, that becomes a barrier to the conversation. So I really like the idea of having that gold standard of taking all this stuff we're talking about and then making sure that every single person who needs to understand it is able to easily access it and comprehend what it is saying and what they need to do. There's some proposed legislation that is trying to lead us to the place that we're talking about. And Marisette, I'm hoping that you can help all this. CTAC does a great job. If you haven't been to the CTAC website or participated in some of their webinars, please do that. They do a really wonderful job outlining bills and ways that you can get involved in advocacy. And they've done a great job summarizing the Improving Access to Advanced Care Planning Act. Marisette, can you tell us a little bit about the components of that and what it proposes and what that might do for the practice of advanced care planning?
Absolutely, Kathleen. And I just want to first of all say thank you for the opportunity to participate in such an important discussion today from the medical legal aspect of advanced care planning, and certainly have enjoyed hearing just the overview from Paul regarding what Five Wishes has done, the evolution really over these last several years in creating those documents and tools for people, and then looking at how medical legal partnerships can really help us. CTAC has really been engaged in looking at what can we do to remove barriers. As we look at everything with the health equity lens, it is our goal and our desire to really remove those impediments that really keep people from having these conversations, especially further upstream and with primary care providers. And so as you reference the advanced care planning legislation, I hate to say we were not able to get it across the bar, during the fall, especially we were hoping we would get it in to one of the end of year packages. It didn't quite make it, but it does not mean that we're going to stop advocating for it. So let me tell you about some of the components of this, because I feel like it's still, Blumenauer and Warner really were getting behind this with us. And it has 4 components that I feel like are still very relevant. The first component that we really wanted to get to was to eliminate the advanced care planning copay that Medicare has after the wellness visit. So if you guys remember in 2016, CMS made available reimbursement to primary care practitioners and others to provide advanced care planning conversations with their patients. They would reimburse them for those conversations. And those conversations can happen at any point in a patient's illness. And so, it was just wonderful. And so as we began to see that, but if those conversations occurred after a Medicare wellness visit, then there is a copay for the patient. Now, you and I know, just as we were just discussing, that there are other trigger points that can happen with a patient. Of course, this is the Medicare population. Medicaid also has some similar things in place. But you could go to the emergency room and need to follow up with your primary care physician later in the year and have to pay this copay in order to have this conversation. And so we wanted to remove that barrier of people having to go into their pockets. The second thing we wanted to look at was how can we increase the workforce in initiating these conversations? And so looking at adding the licensed clinical social workers as another member of the team who could engage in these conversations and bill for that. Right now, we know that nurse practitioners can have these conversations. We also know that physicians are having these. But when we think of workforce, we have to begin to look at who else on the team has the background that would allow them to engage in these conversations to get people thinking about what matters most to them and what they would want. The third thing that we thought about was actually beginning to look at how can we educate providers around these ACP counseling codes and the value of really conducting these particular conversations. We know that primary care practitioners are absolutely busy. They have a checklist of things that they've got to go through. But we also know that many of them have not begun doing this in order to bill. They don't understand that they can bill for an initial conversation, an extended conversation, and then ongoing conversations. And so this would really allow us to educate them on the value and benefit of getting to their patients earlier upstream. I noticed that there was a question in the Q&A about when can this start? And really we want people to begin thinking about this as young adults before they have sort of a medical emergency. We want this to be around the continuum. When you're healthy, what would you think about? And then when things change, or if they change, how do you have that? And so really being able to create that for primary care physicians. In South Carolina, we were involved in creating a care mapping for a couple of primary care practices that work primarily with African Americans and also rural communities. And the very first thing they said to us, we don't have a process to really begin to talk with our patients about advanced care planning and find out, do they have a document, what would they need, et cetera. And that was very rewarding for us through some funding from the Blue Cross Blue Shield South Carolina Foundation to provide that support, educating their teams, but also helping them create a mapping process. And then the last thing that this legislation would do, and of course people need to know the billing codes, right, so they can get reimbursed. But the last thing that this piece of legislation would do would allow for MedPAC to do a study on the effectiveness once you remove the copays, once you educate clinicians, once you expand the workforce who can do this, how effective and what kind of outcomes could we see if we were to put those things in place. And so as I shared, we didn't make it across the bow last year, but we are absolutely picking this back up to work on this again for this legislative session. Gives us another opportunity to educate our national leaders, right? To let them see how important this work is. And really, we want to create access in our underserved and under-resourced communities for this to happen.
Thank you. Yes, we are hoping that this gets across the hurdle at some point. And there's been repeated attempts to pass legislation that addresses some of these things. So I know there will be continued attempts. And I'm hoping that people who are listening are encouraged. There are often opportunities to share if you know of outcomes. This is one of the stickiest things in advanced care planning for healthcare systems, for people to measure meaningful outcomes of advanced care planning activities. We get a lot of counts, counting completions, but that doesn't speak a lot to the quality of care and to the experience of care, and the difference between someone who's had good advanced care planning and someone who has not. How does that affect the clinical outcomes? How does that affect the site of their death? Is their goal concordance? So if you are doing any kind of quality improvement initiatives and you have some data about that, and I know people like to be proprietary with their data, But to the extent that it's shareable, you can share that through channels, sometimes with CTAC, a lot of times when there are open comments for some of these things. Please share that data and share it as a best practice so that other people know how to measure that, because the people doing the work, those of us doing the work every day, really are the people who understand why the things Marisette is talking about are important, and why we need to, why those pieces of legislation really need to pass and just get past the politics of it.
Kathleen, yeah, I would put a plug into that through CTAC. We actually have policy meetups, and we also have state serious illness coalition work group meetings where we talk about a lot of the policy work that people may be doing at the state level and how that can bubble up to the national level. So we really would truly love to have more people engaged. We have over 165 plus members of the coalition, and many of them are working in state serious illness care coalitions like myself in the Carolinas and others. And so we really welcome that engagement, and we learn from each other what that legislative language might look like. Many people have gotten involved in doing, palliative care advisory councils, or looking at, study groups, looking at how they can get the ACP bills turned on. I know in South Carolina, through that state advocacy, we got the ACP bill codes turned on for the commercial payer. And that took us really working together to get that done. So never minimize what you can do as a group, coming together and pooling your resources for that advocacy. So.
A wise man once, 23 years ago, Robert Wood Johnson Foundation funded an initiative that was aimed at creating community coalitions all over the country to try and improve end-of-life care in communities. And I remember, I don't know if I can use his name, so I'll just say a wise man saying to me at some point, if you have a coalition that doesn't include policy work, they're not going to make tremendous sustainable change. And I have seen that come true for 23 years. It is true that if policy work is not addressed and not included, we see change that sometimes goes away when the people who are working at your organization leave. We want things to become institutionalized, and one of the best ways to do that is through policy work that really changes what is possible. I want to get to some questions that came up in the Q&A because they're really good. We had somebody ask a question that I've had myself, and I don't know who can answer this. Maybe everyone can answer this. But when we're working in a healthcare setting with patients and they need some kind of legal resources, what are the best options for free legal resources? That, again, it's one of the barriers to people, including, and it's one of the fears of healthcare providers, is that we're going to send them to a lawyer and they're going to have a ton of money, and they don't have a ton of money. So what are the best resources for patients and families who need some of that kind of advice, and how do we access that as we are caring for people?
It's a great question, and I'm happy to jump in on that one. So we, of course, don't have a Medicare for legal services in this country. And so most of it is self-funded, which is why we have sort of what we call the access to justice problem. But what I can say for low income and even some moderate income folks, we do have a network of legal aid agencies across the country that provide free service. And so there's a website you can go to called lawhelp.org that allows you to put in your zip code and the legal issues that you're looking for, and it will do it by state and by region to help you connect to free resources. For older adults and people with disabilities under the Older Americans Act, we are not allowed to means test. And so if it's an older person You can contact your area agency on aging and find out who their contracted legal provider is. They will not be helpful to somebody who has really a lot of assets and could truly afford to, for instance, pay for long-term care totally out of pocket, which like nobody can. But say you can, don't go to them, please. They're overwhelmed. They're not good at that kind of level of asset. We really need to preserve our scarce legal advocacy resources for the people who really need them. But we do help people who are over the threshold for Medicaid, but who are likely to spend down because of their need for long-term care and other healthcare services. And I saw a note in the chat about someone providing pro bono services who ended up charging. I hate to hear that. That is not a true pro bono service. What some lawyers will do is provide free initial consultation, and then they should be telling you what their fee structure is. And if they're not doing that, that's deeply unethical. They can get disbarred for that. So if someone is holding themselves out as a pro bono resource and ultimately charging, please report them to the state bar. But to go to your state bar for a referral, or go to lawhelp.org, or to your local area agency on aging.
Thank you. That's super helpful. I hope people wrote that down, and just in case they didn't, can you give that website URL again? It's Law Help or Law Health? Law Help.
Help with a P.
Yeah.
.org.
GLP.
Yeah.
Okay. Thank you. There's another question here, and again, I think this is about having better relationships within the communities that you serve, with the between the legal and medical communities. When healthcare providers are asking patients if they have an advance directive, and they do, and that is something that they worked on with an attorney, there are some people who are reporting that they've had the experience of not being able to access that when it's been done with an attorney. That advance directive is owned by the patient, by the person. So that's not, my understanding is that's not something that should be run into. That's something that the patient, the person who did that advance directive, that is their advance directive, and should be shared with everyone in their life who is concerned about what may happen with them at the end of their life. So correct me if I'm wrong, but that's something, if that's happening, I think, ask again, because you ought to be able to get access to that.
Yeah, and I would just say that there may be some things in place in terms of them giving permissions for certain people to give them that information, because it is private. The patient, if they have a copy, we usually encourage them to give those copies to all the people who are significant to them, and especially if you have a healthcare agent. But if you're trying to get it from the lawyer's office and you don't have something that said that they could give it to you, that's not going to work. So we want to encourage people to give that information themselves, make the copies that are necessary. You know, we do have some innovative technology now, which I'm sure Paul would love to talk about, that will allow you to electronically share your documents for people to view it that are in your close circle. But so I'll hush with that. Go ahead, Sam, for Paul.
I was just gonna, real quickly, I was just gonna completely agree with you, Marisette. If I call your doctor and they give me your information, you'd be worried about that, right? It's the same thing with a lawyer. If you call someone's lawyer and say, give me information about your client, they're gonna say no. But the client can always give permission. This is how the medical legal partnership model works. And so as long as everyone has permission to share information, that's okay. But I agree with a larger point that we all should be encouraging the spread of the document, and that was as widely as possible, and good conversations about that. And that's one of the principles and that we agreed on. So Paul, I don't know if you wanted to add something to that.
Sure, and that's all helpful guidance. And I look at it through the lens of what would I tell my own family, my parents or my wife. And Marisette, as you were saying, there are some good new technology tools available with registries, and our 5 Wishes digital option allows for that easy retrieval within a health system or a healthcare setting. My default is to make sure that everyone who might be by my bedside, my caregiver, knows where my 5 Wishes is, and that I know where my parents' document is located, so that I'm not relying on it being found in the electronic medical record or on a registry somewhere. I found that even with my own parents, once we had submitted my mom's completed 5 Wishes, I was asked for it several times. And if the only place where it existed was in the electronic medical record, it would have been a challenge. And back to basic technology, I had a PDF of it on my phone, and I could provide it whenever I needed to do that. So I think those kind of simple solutions are helpful. And then what we exist to do too is to answer the questions that are specific to advanced care planning that come up. We are not staffed with attorneys, so we can't answer the broader legal questions on all the aging issues. And that's why it's so important that Sarah provided the resources that she did. But for families, for caregivers, for healthcare providers, if there are specific questions regarding legal issues and advanced care planning, we're happy to find the answers to those. We have a national toll-free hotline that's on the back of every 5 Wishes, and it's on our 5 Wishes website too, so that you're not left on your own to try to figure out the answers. Or even if legal counsel has questions, we can help find those answers that will give everybody peace of mind to know that they're following the right instructions and following the laws of the state.
And I had one other thing to share, Kathleen, quickly, and that is that, you may have a community that's not technology savvy, or they may not have had the forms. And so we really also want to encourage families to have conversations. Some of our communities have an oral history, and so they pass the stories down and talk to people about what happened with mama and grandma and grandpa, and so what would you want? And so we really want to, in the culture that we're in, a lot of times we don't have conversations. And before you can get to a document, there needs to be conversations that we have with one another. I'm always talking to my husband about what I might want. Through the seasons of our life together as a couple, when we were having babies, okay, what would I want now? If something were to happen to me. Now we're on the other side, we're empty nesters. And so we still have to have those conversations so that if you can't get your hand on the document, you know what that person said. And you could be asked, what do you think they would want? I absolutely agree that we should have a piece of paper that is legally executed, right? But in lieu of that, we still need to have those conversations.
Right, and in lieu of or in addition to, because if you can still have the document, and if the conversations didn't take place, and again, I think we've all been at a bedside once where this happened, and once is enough to burn it into your memory. No offense to daughters from out of town, but the daughter from out of town comes in, and that's not her understanding. And in the moment, I mean, there have been a few questions with people asking, what is the definition of advanced care planning? So just in short, to give, I think, a simple definition of that, the purpose of advanced care planning is to prepare people to make decisions about end of life care in the moments where those needs have emerged. That's the purpose of it. You can have the conversation well in advance from the time you're 18 on. And again, we want to revisit those conversations anytime there's a significant change that would change what you want or whether you can have what it is that you might say you want. We want to revisit those conversations to better inform the choices. But the purpose of it is so that when the time comes, the decision, people can make the decision in real time. And that includes the medical professionals. If they're looking at something that is impossible to do, somebody wants CPR, but they don't want to be intubated, that does not happen. It has to be something that can be understood by the family members, by the people who are there in the moment who can honor those wishes, by any legal professional who you might take it to. That's the purpose of having all these people collaborate to ensure that the end product is something that empowers people to make decisions in the moment. So it's appropriate at any age. It should be done at various stages, as Marisette was saying. There have been some specific questions about 5 wishes, and what I'll say is that we're capturing all of your questions. If we don't get to it on the live today, we'll answer you through an email, just so we don't spend too much time talking about the specifics of 5 wishes, which is an advanced directive document and guide for the conversations. We'll get back to you about that, and because you're already probably using it, if you're on this webinar, we want to make sure that you've got the correct information. There's one question that I think is pretty good and goes back to some of what we were just talking about with there being now new advanced directive storage options. There's someone who's saying she does advanced care planning as a social worker, and she has she's wondering, where can the advanced directive be stored so that it is available to so that we have care coordination, so that it's available to all the people who may have an interest in that. And the short answer to that is it should be in your medical record. It absolutely should be stored in the medical record. The medical record, the electronic medical record, or however it's done at your place, is supposed to be the one truth, where if it wasn't you that worked with this person, the next person that works with them ought to be able to look at that record and understand the conversation that happened, any decisions that were made, any decisions that need to be made, and information that needs to be filled in. How you get it there is the harder part of that answer. And there are lots of different electronic health record, medical record solutions available now for advanced directives and advanced care planning. And there are national directories. Whether or not your organization will approve accessing the directive out of those national directories is another. That's kind of where I wanted to go with all of us today. Those things exist, but how well in reality are they talking to medical systems right now? How easy is it to import an advanced directive document from national online storage entity into a medical record? Are we making patients do it 3 or 4 times again? That's my concern.
Yeah, I would say that we've come a long way with the technology. Integrations and interfaces are created so that it can be seamless. The piece is whether or not that organization is going to put forth the resources to have that integration, so you have that seamless ability to look from one entity through to another entity to see the documents. But the technology is absolutely there. It just depends on the state and the health system and the resources that they're putting in place to make that seamless for their providers, so they don't have to look 2 places. Most of your EMRs with health systems have an advanced care planning banner in the record, so that everybody knows to go to that particular section of the chart and can see all of the conversations. But they're really working hard to integrate outpatient with inpatient and the folks that are in community. And that's where we have disparate systems. When you think about community and technology versus a health system and technology, that's where some things don't, you may not be able to see everything. And so we still have some work to do, but it's a whole lot better than it was 10 years ago in terms of being able to not have to go 3 places or upload something 3 different places in order to see what a patient's record is. We absolutely want to have ready access. And if you have, I would put a plug in for information health exchanges, because they connect to all the systems. And in some states, they also connect to the outpatient systems as well. And that would work really well. But each of our states have different things going on. So, and health systems have gotten a lot more savvy with that. And I'll just hush and let someone else chime in.
I think that's true. And I think what we've seen with many of our healthcare partners is that it's really difficult capacity wise to ask healthcare providers to look somewhere where they aren't already looking, right? If they're not already seeing it in their electronic medical record, Epic or Cerner, finding a way to inject that into the platform that they're already looking at, it's going to be a lot harder. So I know some of our work with our practice community has been in helping to join those two different dots together and answer the questions of how a health system would do that. Or as Marisette said, with the health information exchanges, the state coordinated registries. I think if there's a way that you can put it in front of the healthcare providers on a dashboard that they're already looking at, that can be helpful. But then back to my own, what would I do for my family? I'd make sure it was there, and I'd make sure that my wife knows where a copy is and that we've discussed it so that she's ready to make a decision for me.
Paper is still something that I know we all want to get rid of it, but it's still something that seems to, I don't know if we ever will. And I don't know that we need to keep fighting that so hard. I think we do what works best for patients and families. And if that means, you know, form follows function, then I think sometimes we have to, out of respect for our panelists and everyone who's participating. Again, thank you so much, Marisette, Sarah, Paul. This has been wonderful. There's so much more to talk about. To remind everyone, we will send out a follow-up email. We will include the links that have been mentioned and the resources that have been mentioned. We will respond to the questions that we didn't get to live today, your specific questions about 5 wishes and using those tools, etc. We will send that in a follow-up email. And thank you to everyone who participated today. And Dave, I'll pitch it back to you.
Thank you. And just as a reminder, this presentation was recorded. It will be available for you to view within 7 business days. And you can find it and all of our other recorded webinars in our webinar library at 5wishes.org/webinars. We encourage you to share this with your colleagues. And as Kathleen mentioned, we will send out an email letting you know when it's available and also include links that were mentioned today. On behalf of all of us at 5 Wishes, thank you to our speakers and of course to you for participating. Have a wonderful afternoon.